Welcome to the Rad Onc Smart Review Genitourinary Cancer Series.
Glad to be here.
Episode 1. Prostate, Anatomy, Pathology, Risk Groups, and Natural History.
Right. Let's get into it.
So, imagine a disease where like 98% of people survive.
Yeah, which is incredible, really.
Right, but it still manages to kill over 36,000 men a year. That is the central paradox of prostate cancer.
It totally is. It's a massive contradiction, and it really defines this entire field.
Yeah.
Like, if you look at the American Cancer Society estimates for 2026, they're projecting approximately 333,830 new cases in the U.S. alone.
That's a huge number.
Right. And the incidence has been creeping up like about 3% annually since 2014.
Wow.
But what's truly concerning is that this rise is largely driven by regional and metastatic presentations.
Ah, right, which is like a direct consequence of that post-screening decline, right?
Exactly. When the USPSTF temporarily recommended against routine PSA testing earlier in the decade.
Right.
Yet, despite all that volume, the 5-year relative survival for all stages combined is still that staggering 98% you mentioned.
Which basically means for the vast majority of patients you see in the clinic, this disease is, well, incredibly indolent.
Yeah, it'll just sit there.
Exactly.
Yeah.
But when it does take on its aggressive metastatic forms, it is undeniably lethal.
Right. And your entire career in radiation oncology will be spent navigating this tightrope.
Yeah, like finding the lethal tumors before they escape, right?
Exactly. But doing it without inflicting the morbidity of overtreatment on the men whose tumors were, never going to harm them anyway.
Totally. And before we get into the biological mechanics of how to separate the dangerous from the dormant, we really have to establish a crucial epidemiological reality.
Right, the disparities.
Yeah, there are significant racial disparities woven into this disease. The incidence in black men is approximately 67% higher than in white men.
Which is just staggering. And even more alarming, the mortality is roughly twofold higher.
Right. And that disparity isn't just like a trivia fact. It impacts exactly how we think about screening windows and surveillance eligibility.
Absolutely.
The biological drivers, whether they're related to genomic differences in the tumor microenvironments, inflammatory pathways, or just, socioeconomic access to early multiparametric MRI and targeted biopsies, they're incredibly complex.
Yeah, and actively researched.
Right. But clinically, you have to keep that demographic reality at the absolute forefront of your mind for every single patient interaction.
Totally. And to navigate this paradox, you can't just memorize tables.
Oh, definitely not.
You really have to build a rigorous, systematic framework based on anatomy and tumor biology. So we're going to build that foundation today.
Because every complex downstream decision, right?
Yep.
Like dose escalation, hypofractionation, brachytherapy boosts, the integration of androgen deprivation therapy.
Right, all of it.
All of it depends entirely on the rules we establish in this session. So let's anchor this in a concrete clinical case.
Let's do it.
Okay, so you are evaluating a 62-year-old man in the clinic. He was referred by his urologist after a PSA of 6.8 on routine screening.
Okay, pretty low.
Yeah, he's in excellent health. He runs 3 times a week. BMI is 24, well-controlled hypertension on just a single agent.
Okay.
And no family history of prostate cancer.
Got it. So the standard workup begins with the digital rectal exam, the DRE. What do we actually feel?
Well, you identify a small, firm nodule on the left side. It involves less than half of the left lobe.
All right.
And crucially, it feels entirely confined within the boundaries of the gland.
Okay, good. And moving to imaging.
The pelvic multiparametric MRI shows a PIRDS4 lesion in the left peripheral zone. The imaging shows no extra prostatic extension, so no EPE, and no seminal vesical invasion.
Let's briefly pause on that MRI finding, actually.
Sure.
A PIRDS4 lesion means it is highly likely to be clinically significant cancer.
Right.
Mechanically, what the MRI is doing is detecting restricted diffusion of water molecules.
Oh, because the cells are so packed together.
Yeah, exactly. Prostate cancer cells are incredibly densely packed with very little extracellular space, so water just cannot move freely.
Okay.
That shows up as a bright spot on diffusion-weighted imaging and a really dark spot on the apparent diffusion coefficient, or ADC, map.
Right.
So what did the biopsy confirm?
Right, so he underwent a systematic 12-core transrectal ultrasound biopsy, plus MRI-targeted cores directed at that specific PIRS4 lesion.
Okay.
The pathology report shows conventional acinar adenocarcinoma, Gleason 3 plus 4/7.
Which translates to ISIP grade group 2.
Exactly. And this is present in 3 out of the 12 systematic cores,
Huh.
with a maximum core involvement of 30%.
Okay.
There is no paraneural invasion. The targeted cores also confirm grade group 2.
Perfect. Now, the mission of this session is not to jump to a treatment recommendation right away.
Right, we're not there yet.
We need to answer the foundational questions first, like how do we classify this specific cellular architecture?
Right.
What does his anatomy tell us about how this tumor arose and where it's trying to spread?
Yeah.
What risk group does he belong to? And most importantly, what does the natural history of this specific biology predict over his remaining lifespan?
So, to prove we can synthesize all of those variables, we are going to fast forward to your oral boards.
Ah, the hot seat.
Yep, I'm going to step into the shoes of the resident. I've just been handed this clinical vignette. The examiner is staring at me, and I need to deliver the board script exactly as it is expected to be recited.
Let's hear it. Go ahead.
62 Yeoman, PSA 6.8, low stratum. DRE nodule left half, CT2A.
Yeah.
GG2, Gleason 3 plus 4/7 in 312 cores, 30% max. One intermediate risk factor, GG2, not GG3, 50% cores positive. And CCN, favorable intermediate risk, AGCC stage 2B. Favorable intermediate shows excellent cancer-specific survival at 15 years, but GG2 signals higher reclassification progression potential than GG1.
Nailed it. That is the exact reflex-level delivery required.
Thanks.
You state the facts, categorize the risk, and immediately tie it to the natural history implication.
Yep.
But to understand why calling it favorable intermediate isn't just, a memorized label, but a profound statement about cellular biology and anatomical containment, we really need to unpack the underlying mechanisms.
Yeah, let's start at the microscopic level with pathology. The report noted conventional acinar adenocarcinoma.
Right.
That accounts for over 95% of all prostate cancers. These tumors arise from the secretory cells lining the prostate, Cassini-like, the tiny sacs that produce the fluid component of semen.
Exactly.
But there are variants, right? Ductal, mucinous, signet ring. What is the one histologic variant that should instantly change your entire management paradigm?
Oh, that would be small cell or neuroendocrine differentiation.
Okay.
If you see that on a pathology report, the standard prostate cancer playbook completely goes out the window.
Wow, really?
Yeah. Acinar cells rely on androgen signaling to survive and grow. Neuroendocrine cells just do not. They are a completely different lineage.
Right.
Because of this, they exhibit incredibly aggressive, rapid growth.
And mechanically, because they aren't acinar cells, they don't produce prostate-specific antigen, right?
Precisely. And this creates a classic, dangerous clinical trap.
Like what?
You will see a patient with massive, bulky pelvic disease or liver metastases on a PET CT, but their PSA might be like 1.2.
Oh, wow. So it totally fools you.
Exactly. The tumor volume is entirely discordant with the biochemical marker. Because these cells don't express the androgen receptor, standard androgen deprivation therapy, ADT, will fail completely.
So what do you do?
These tumors require platinum-based chemotherapy, much like small cell lung cancer.
Okay, that makes sense.
So if you see a rapidly progressive tumor with a low PSA, neuroendocrine differentiation absolutely must be at the top of your differential.
Got it. Okay. Moving from the microscopic cells to the macroscopic gland, let's map out the zonal anatomy.
Good idea.
Because a prostate is not a uniform organ, right? It's divided into 4 distinct zones. And the microenvironment of each zone really dictates clinical behavior.
Yeah, let's begin with the peripheral zone. This tissue makes up about 70% of the normal gland volume.
Okay.
And it forms a shell around the posterior and posterolateral aspects of the prostate. Crucially, 80 to 85% of all prostate cancers originate right here.
Which perfectly explains the mechanics of our diagnostics, right?
Exactly.
The peripheral zone is separated from the anterior wall of the rectum by only a thin fascial layer called Denonvillier's fascia.
Right.
Because the cancer originates posteriorly, when you perform a DRE, your finger is sweeping directly over the exact zone where the vast majority of tumors live.
Right. It also dictates why the traditional systematic transrectal ultrasound biopsy, the TRUS biopsy, is so effective at catching early disease.
Because the needles go right into that zone.
Exactly. The needles are deploying directly through the rectal wall into that posterior peripheral tissue.
Makes sense.
However, from a therapeutic standpoint, this anatomic proximity is our greatest challenge.
The rectum is right there.
Yeah. The rectum is our most critical dose-limiting organ at risk. The cancer is literally abutting the anterior rectal wall, meaning any curative radiation dose delivered to the peripheral zone is going to deposit significant scatter into the rectal mucosa.
risking proctitis or bleeding.
Exactly.
So the second zone is the transition zone. This tissue surrounds the proximal urethra as it exits the bladder.
Right.
This is the origin site for benign prostatic hyperplasia, BPH, which compresses the urethra and causes voiding issues in older men.
And it is also the origin site for 10 to 15% of prostate cancers.
Okay, and this is where the blind spots in our diagnostics appear.
A big time. A standard systematic TRUS biopsy deploys needles posteriorly. It frequently just cannot reach deep enough or anteriorly enough to adequately sample the transition zones.
Because they were missing them.
For decades, transition zone tumors were notoriously missed until they grew massive.
Wow.
This anatomical blind spot is the fundamental biological rationale for why a multiparametric MRI is now standard of care.
Because it sees everything.
Exactly. The MRI visualizes the entire gland, allowing us to see those hidden transition zone tumors and target them specifically with software-fused biopsies.
Right. Next is the central zone. This sits at the base of the prostate up near the seminal vesicles.
Right, making up about 25% of the tissue.
But only 5 to 10% of primary cancers originate here.
True, primary central zone cancers are rare, but the central zone is frequently invaded secondarily by large peripheral zone tumors that track superiorly toward the base.
Ah, okay.
You absolutely have to account for this superior spread pattern when contouring your clinical target volumes.
Makes sense. Finally, the anterior fibromuscular stroma.
Right.
It contains no glandular tissue, just smooth muscle and fibrous tissue, so it does not generate adenocarcinoma. It forms the anterior surface of the prostate, abutting the retropubic space and the pubic symphysis.
So the mnemonic to burn into your memory for cancer origins is PTC?
PTC.
Peripheral most, transition middle, central least?
So peripheral is 80 to 85%.
Right.
Transition is 10 to 15%.
Central is 5 to 10%.
Exactly. Say it to yourself until it sticks.
Now let's trace how the cancer escapes. We need to look at the structures immediately adjacent to the gland.
Okay, let's start superiorly with the seminal vesicles.
These are paired glands that sit behind the bladder and converge at the base of the prostate to form the ejaculatory ducts.
Right. Prostate cancer typically invades the seminal vesicles by tracking directly up the ejaculatory ducts or extending through the base of the prostate.
Okay.
But there is a vital pathological distinction regarding staging here.
What's that?
True seminal vesicle invasion, which is classified as pathologic T3B, requires the tumor cells to physically infiltrate the muscular wall of the seminal vesicle itself.
Okay, so wait. If the pathologist sees tumor cells just floating in the fat surrounding the seminal vesicle, how is that classified?
Ah, that is classified as tumor in the periseminal vesicle fat, which is pathologic T3A.
Really? So it's not T3B?
No, it is considered extraprostatic extension, not true seminal vesicle invasion.
Okay, why? The biology is different. Invading the muscular wall implies a much more aggressive, deeply infiltrative phenotype than merely pushing into adjacent fat.
Got it.
And the T3B designation carries a correspondingly much higher risk of systemic failure.
Okay, moving laterally, we find the neurovascular bundles. These run along the posterolateral edges of the prostate.
Right.
And they contain the delicate cavernous nerves that govern erectile function.
And here we find the cruelest anatomical irony of prostate cancer.
Yeah.
We already established that 85% of tumors arise in the peripheral zone.
Right.
Well, the most common anatomical route for these tumors to break out of the prostate extraprostatic extension is posterolaterally.
Right into the bundles.
Exactly. The cancer is escaping exactly where the erectile nerves are located.
So for surgeons, it forces this terrible choice during a prostatectomy, right? Like, do you cut wide to ensure negative margins and sacrifice the nerve? Or do you spare the nerve and risk leaving microscopic cancer behind?
Precisely. And for radiation oncologists, it means we have to deliver full curative doses right up to and often encompassing those neurovascular bundles.
Which explains the gradual rate of erectile dysfunction post-radiation, right, as vascular fibrosis sets in.
Unfortunately, yes. And the barrier separating the cancer from those nerves is the prostate capsule.
But the term capsule is kind of misleading, isn't it?
It totally is. It is not a distinct, thick anatomical shell like the renal capsule.
Right. The best way to visualize the prostate capsule is to imagine a tightly woven mesh of fibromuscular tissue.
That analogy.
On the posterior and posterolateral sides, the mesh is woven quite tightly. You can clearly see where the prostate ends and the paraprostatic fat begins.
Right.
But at the edges, specifically at the apex inferiorly, the anterior surface and the bladder neck superiorly, that mesh just frays and completely disappears.
Yeah. There is no true capsule in those locations.
Which must create a massive headache for pathologists.
Oh, absolutely. Think about it. If a tumor extends posterolaterally, the pathologist can clearly see it cross the boundary of the mesh into the fat.
Right.
That is definitively extraprostatic extension, PT3A, and it's a highly validated predictor of recurrence.
But what happens at the apex?
Exactly. Because there is no capsular boundary to cross, the pathologist simply cannot definitively identify extraprostatic extension.
Wow.
By convention, even if a tumor is found at the absolute distal margin of an apical section, it is still classified as organ-confined, pathologic T2.
That is a really critical nuance.
It is.
Apical extension is functionally impossible to define pathologically. So when you read a path report, don't just look for EPE present.
Right. Look for the location.
Posterolateral EPE changes your risk profile. Apical disease is a margin risk, but it's staged differently.
Spot on. Now, once a tumor escapes the local neighborhood, it utilizes the lymphatic system.
Right.
Prostate lymphatic drainage follows a very specific hierarchical flow. From the periprostatic plexus to the obturator nodes, then to the internal and external iliac nodes, and up to the presacral nodes.
And the oral board examiners are going to hunt for your understanding of this exact drainage basin.
Oh, they definitely will.
You must know the strict anatomical dividing line between regional spread and distant metastasis.
And that dividing line is the bifurcation of the common iliac arteries.
Okay.
Any lymph node located below that bifurcation obturator, internal iliac, external iliac, presacral, is considered a regional node.
Right.
Involvement here is N1 disease, which translates to stage 4A.
So why does this anatomical line matter so much biologically?
Because if the disease is confined to regional nodes, the sheer volume of tumor burden is still considered potentially curable.
Okay.
We can design a comprehensive pelvic radiation field that covers all of those N1 nodes below the bifurcation, paired with long-term androgen deprivation therapy, and aim for a cure. But the moment the cancer ascends above that bifurcation into the common iliac nodes or the periaortic nodes, the biology has declared itself as widely disseminated.
Right. Those nodes above the bifurcation are classified as non-regional, that is M1A disease, stage 4B.
Exactly.
The intent of treatment shifts from definitive local cure to systemic disease control. So the rule is absolute. Regional equals below the bifurcation, common iliac and above equals M1A.
Perfect. Finally, hematogenous spread.
The bloodstream.
Right. When prostate cancer enters the bloodstream, it has a profound, almost exclusive affinity for bone.
But it interacts with the skeletal system differently than almost any other solid tumor, doesn't it?
It really does. Breast and lung cancers typically cause osteolytic metastases. They activate osteoclasts, which eat away and destroy the bone matrix, creating holes.
Prostate cancer does the opposite.
Yep.
It secretes factors like endothelin-1 that hypostimulate osteoblasts, the cells that build bone. This results in osteoblastic metastases. The bone being built is disorganized, dense, and structurally weak, which still leads to severe pain and pathologic fractures. But it appears as bright, sclerotic lesions on imaging rather than dark, olytic holes.
Right. Visceral metastases to the liver or lungs do happen, but generally much later in the disease course, typically after the tumor has mutated to become castration-resistant.
Okay, so we've mapped the anatomy. Now we must use that anatomy, along with the biochemistry and the pathology, to assign our patient to a risk category.
Right.
This is governed by what we call the 4 pillars of risk classification.
Every localized prostate cancer patient is sorted based on these 4 variables.
Let's construct Pillar 1, clinical T-stage.
The rule here is absolute and non-negotiable for board purposes. Clinical T-stage is determined by the digital rectal exam alone.
Okay, wait, I have to stop you there because this rule feels completely archaic.
I know.
We have multiparametric MRI now. If I have a patient whose DRE is completely normal, smooth, no nodules, but his biopsy comes back with grade group 2 cancer, both the right and left sides, we biologically know the cancer is bilateral.
We do.
How can I not stage that as T2C, which is bilateral disease?
I completely understand the frustration, but it remains T1C.
Really?
Yes. The clinical staging system maintained by the AJCC is rigidly anchored to the DRE to preserve the integrity of decades of historical prognostic data. If we suddenly started upstaging every bilateral biopsy to T2C, we would cause massive stage migration.
Right.
The historical survival curves for T2C were based on men who had large, palpable, bilateral bulky tumors.
That makes sense.
A man with microscopic bilateral disease found only on a needle biopsy simply does not have the same biological risk as a man with a prostate that feels like a rock on both sides.
Okay, yeah.
Therefore, imaging and biopsy laterality cannot upgrade the clinical T category.
That actually makes biological sense when you explain it that way. We're preserving the prognostic power of the palpability.
Exactly.
Let's review the exact AJCC 8th edition clinical T categories. T1 is clinically inapparent disease. It's not palpable.
Right.
T1A is incidental cancer found in less than or equal to 5% of tissue removed during a TURP, a transurethral resection for benign enlargement.
Yeah.
T1B is incidental cancer in greater than 5% of 2RP tissue.
Correct.
T1C is tumor identified by needle biopsy, but totally non-palpable. And T1C accounts for the vast majority of modern PSA-screened patients.
Absolutely. Then T2 disease means the tumor is palpable but feels confined within the prostate.
Right.
T2A involves 1/2 of one lobe or less. T2B involves more than half of one lobe, but not both. T2C is palpable on both the left and the right lobes.
And T3 disease means it is palpable outside the boundaries of the gland.
Exactly.
T3A is palpable extraprostatic extension. T3B is palpable seminal vesicle invasion.
And T4 is massive local disease. The tumor is fixed or invading adjacent structures other than the seminal vesicles, such as the external sphincter, the rectum, the bladder, or the pelvic sidewall.
Right.
Now, while clinical staging relies on the DRE, there was a major, frequently tested update to the pathological staging in the AJCC 8th edition.
Oh, right. They completely eliminated the subdivisions of pathological T2.
Yes.
There's no more PT2A, PT2B, or PT2C. It is all just PT2.
Exactly. When pathologists reviewed massive prostatectomy databases, they realized something important.
What's that?
Once a prostate is removed and the cancer is proven to be strictly organ-confined, the specific location or bilaterality within the gland had zero independent impact on biochemical recurrence or survival.
Wow. Organ-confined is organ-confined.
Exactly. So they simplified it.
The other major 8th edition update involved bladder neck invasion, right?
Yes.
Historically, if the pathologist saw microscopic tumor cells invading the smooth muscle bundles of the bladder neck, it was classified as PT4.
Which sounded devastating to patients.
Right. But the 8th edition downgraded microscopic bladder neck invasion to PT3A.
The biology dictates this change. Microscopic infiltration at the bladder neck behaves clinically like extraprostatic extension anywhere else. It does not carry the dire prognosis of macroscopic gross invasion of the bladder wall.
Right.
Remember that downgrade?
Yeah.
Microscopic bladder neck invasion is PT3A.
Got it. Okay. Pillar 2 is the prostate-specific antigen, the PSA.
Right.
PSA is a serine protease produced by the prostatic acinar cells to liquefy semen. Normally, very little escapes into the bloodstream.
Exactly.
But when cancer destroys the basal cell layer and the basement membrane of the acini, PSA leaks directly into the capillaries.
Right. And the raw PSA values are stratified simply. Less than 10 is low, 10 to 20 is intermediate, greater than 20 is high.
Nice and simple.
A PSA over 100 without known metastases is a massive red flag for systemic spread.
Yeah.
But the crucial biological refinement of this pillar is PSA density.
PSA density is the total PSA divided by the total volume of the prostate gland in cubic centimeters.
Right. Exactly. And why does this matter? Because benign hyperplastic tissue in the transition zone also leaks PSA. If you have a man with a PSA of 6, but his prostate is a massive 60 cubic centimeters due to BPH, his density is only 0.10.
So most of that PSA is just coming from benign tissue.
Exactly. But if a man has a PSA of 6 and a tiny 20 cubic centimeter prostate, his density is 0.30.
Oh, okay.
That high density suggests a small, highly active focus of cancer is pumping out the antigen.
Right. A PSA density less than 0.15 is considered favorable. In fact, it's a strict prerequisite for a patient to be classified into the very low-risk category.
Spot on. Pillar 3 is the grade group. This represents the architectural breakdown of the prostate cells.
Right.
The field has transitioned from the traditional Gleason scoring to the ISUP grade groups, numbered 1 through 5.
Because the old Gleason system was problematic, right? Pathologists essentially stopped assigning pattern 1 or 2.
Right. They basically didn't exist anymore.
So the lowest score given in the modern era became 3 + 3 = 6. Patients were told they had a 6 out of 10 cancer, which sounds highly aggressive, even though a pure Gleason 6 tumor functionally lacks the biological machinery to metastasize.
Exactly. To correct this psychological harm, the ISUP consensus mapped the Gleason scores to 5 intuitive grade groups.
Let's run through them.
Grade group 1 is a Gleason 3 plus 3 equals 6. Under the microscope, these are entirely well-formed, separate, discrete glands. The architectural blueprint is still mostly intact.
Okay.
Grade group 2 is a Gleason 3 plus 4 is 7. The primary pattern is well-formed glands, but there is a lesser secondary component of pattern 4.
And pattern 4 means what?
Pattern 4 means the glands are poorly formed, fused together, or cribriform, meaning they look like a sieve with punched-out holes.
Oh, got it.
Grade group 3 is a Gleason 4 plus 3 equals 7. This is the inflection point. Now, the primary dominant pattern is those poorly formed, fused, or cribriform glands, with a minority of well-formed pattern 3.
And that transition from grade group 2 to grade group 3 is perhaps the most critical biological threshold in all of localized prostate cancer.
It really is.
When the cells lose their architecture and fuse together, they are losing their cellular adhesion molecules. They are acquiring the physical ability to detach and migrate.
Exactly. And the clinical data perfectly mirrors that biological shift. In massive surgical cohorts, the 5-year biochemical recurrence-free survival for grade group 1 is 96%.
Right.
For grade group 2, it drops slightly to 88%.
Still pretty good.
But for grade group 3, it plummets to 63%.
Wow.
Even though both are technically Gleason 7, the 4 plus 3 tumor has a significantly higher rate of distant metastasis and cancer-specific mortality.
Which is exactly why grade group 3 immediately disqualifies a patient from favorable intermediate risk.
Precisely.
Finishing out the grading, grade group 4 is a Gleason 8, which is any combination of patterns 4 and 5.
Right.
Pattern 5 means there is no gland formation at all. It is just solid sheets or single infiltrating cells. And grade group 5 is a Gleason 9 or 10, meaning it is predominantly or entirely pattern 5, highly aggressive, completely disorganized disease.
Perfect. So pillar 4 is the percent positive cores.
Right.
This is a surrogate marker for the total physical volume of the tumor within the gland. The critical threshold to memorize here is 50%.
And the logic here is straightforward, right? A patient with grade group 2 cancer in a single, tiny 2-millimeter focus has a profoundly different biological risk than a patient whose prostate is riddled with grade group 2 disease across 80% of his biopsy cores.
Absolutely. Landmark research by Zimsteg and colleagues proved that among intermediate risk patients, having 50% or more positive cores predicted worse recurrence-free survival, higher metastasis rates, and higher mortality.
Because the sheer volume of disease increases the statistical probability that some of those cells have acquired the mutations necessary to escape.
Exactly. Because of this, the 50% rule is hardwired into the NCCN criteria.
Okay, we have our 4 pillars: clinical T-stage by DRE, PSA, grade group, and percent positive cores.
Right.
Now we integrate them into the diagnostic sorting framework. The if-then risk ladder. You must be able to categorize any patient reflexively. Let's build the ladder.
Starting at the bottom. Very low risk.
Okay.
This requires meeting incredibly strict criteria. Clinical T1C, grade group 1, PSA less than 10. You must have fewer than 3 positive cores. No single core can have 50% or more involvement. And D, your PSA density must be less than 0.15.
Wow, that is strict.
You must meet every single one of those constraints. The tumor is microscopic, incredibly indolent, and producing very little PSA.
Moving up one step, low risk. This is T1 to T2A, grade group 1, PSA less than 10.
Right.
But the patient does not meet the strict volume or density cutoffs for very low risk. They might have 4 positive cores or a density of 0.18.
Now, for the most complex category, intermediate risk.
Oh boy.
This cohort is defined by having no high-risk features, but possessing 1 or more intermediate risk factors, or IRFs. The IRFs are T2B to T2C, grade group 2 or 3, or PSA between 10 and 20. But because the biology within this group varies so wildly, we must split it into favorable and unfavorable.
And favorable intermediate risk requires you to thread a very specific needle. You must meet all of the following. You have exactly 1 intermediate risk factor.
Right.
You are not grade group 3. And you have less than 50% positive cores.
Exactly. Unfavorable intermediate risk is everything else in the bucket. If you have 2 or more IRFs, or if you have grade group 3 disease, or if you have 50% or more positive cores.
Any single violation bumps you to unfavorable.
Right, which completely changes the systemic therapy and radiation dose requirement.
Then high risk. You are high risk if you have exactly one high-risk feature.
Yeah.
T3A, which is extraprostatic extension, grade group 4 or 5, or PSA greater than or equal to 20.
And finally, very high risk. This is reserved for massive or rapidly disseminating local disease, T3B to T4, or a primary Gleason pattern of 5, or 2 to 3 high-risk features simultaneously, or greater than 4 cores of grade group 4 or 5 disease.
Let's apply this directly to the 62-year-old case we introduced at the start. His DRE was a small nodule on the left, T2A. His PSA was 6.8. He was grade group 2, and he had 3 out of 12 cores positive, which is 25%.
Let's run the algorithm. He has one intermediate risk factor, which is the grade group 2.
Right.
He is not grade group 3. His cores are at 25%, which is less than 50%.
Yep.
So he meets all the criteria for favorable intermediate risk.
Which brings us to the most intellectually demanding part of prostate oncology. We've categorized his cancer biology. But what does favorable actually mean over a timeline of 20 or 25 years?
That's the real question.
If we do nothing, what happens? If we treat him, what changes? This requires us to understand the natural history of the disease through the lens of competing risks.
Prostate cancer is a unique oncological entity. It does not kill in months, it kills over decades. To conceptualize competing risks, think of it as a race.
The race.
Right. The prostate cancer is a tortoise, moving slowly but steadily toward the finish line, which is mortality. The patient's cardiovascular disease, pulmonary issues, and sheer age are the hares.
Right. If the finish line is only 5 years away because the patient is 80 years old with severe heart failure, the tortoise is never going to win the race.
Exactly. The hare will cross the finish line first.
But in that scenario, treating the tortoise is pointless.
Right.
But if the patient is our 62-year-old runner with a 25-year lifespan ahead of him, the finish line is miles away. Suddenly, that slow-moving tortoise becomes a massive, lethal threat.
To prove this mathematically, we rely on 4 landmark randomized data sets that establish exactly how fast the tortoise moves depending on its grade group.
Let's start with the longest follow-up we have, the
Alright.
Scandinavian SPCG4 trial.
SPCG4.
This trial randomized 695 men with early prostate cancer to radical prostatectomy versus watchful waiting. Now, you have to understand the historical context. This was largely the pre-PSA era.
Right.
These men were diagnosed because they had symptomatic or palpable tumors. The mean age was 65, and the mean PSA was roughly 13.
We have an astounding 29 years of follow-up on this cohort. What happens?
At 29 years, definitive treatment mattered immensely. Surgery significantly reduced prostate cancer death. 20% of the surgery arm died of the disease, compared to 31% in the watchful waiting arm.
Right.
That yields a number needed to treat, an NNT, of 8.3. You have to operate on about 8 men to prevent 1 prostate cancer death over 3 decades.
And the subgroup analysis reveals the biology. The benefit was highly concentrated in men under 65, where surgery nearly halved the risk of cancer death.
Wow.
And crucially, the absolute benefit was most pronounced in intermediate risk disease. Extracapsular extension carried a 5-fold increased risk of death, and a Gleason 7 carried a 10-fold increased risk.
The biological takeaway from SPCG4 is indisputable. Untreated, clinically apparent intermediate risk prostate cancer will eventually kill the host if given enough decades to grow.
Right. Definitive treatment alters that fatal trajectory.
But we must appraise it accurately. These were bulky pre-PSA era tumors. The tortoise had a massive head start. So let's look at the PIVOT trial, which randomized 740 men to surgery versus observation, but in a very different population.
Right.
The mean age was older at 67. They were PSA screened, and crucially, they were a much sicker demographic with heavy medical comorbidities.
PIVOT proves the competing risk race perfectly. By 10 years, half of the entire trial population had died from any cause.
Calf.
Their life expectancies were far shorter than the investigators initially guessed. Because the hares were running so fast, treating the tortoise yielded minimal benefit.
Right.
At 19.5 years, surgery showed a near significant overall survival improvement, but the benefit was entirely restricted to patients with a PSA greater than 10 and intermediate risk disease.
What about low risk?
For low-risk disease, surgery provided 0 mortality benefit. Competing causes of death completely dominated the picture for low-risk sick men.
Now let's move to the modern PSA screened era with the PROTECT trial. This randomized 1,643 men, aged 50 to 69, to active monitoring surgery or radiation.
Right.
This was a heavily low-risk cohort. 77% had Gleason 6 disease.
At 15 years, the cancer-specific mortality was incredibly low across all three arms, around 1.5 to 2.2%. The survival was excellent whether they were monitored or treated immediately.
Okay, wait, I have to push back here.
Sure.
You're saying mortality was equal. But PROTECT also showed that metastatic disease doubled in the active monitoring arm, 9% developed mets, compared to only 4 or 5% in the surgery and radiation arms.
Yes, that's true.
If monitoring doubles the rate at which the cancer escapes into the bones, how can we possibly consider active surveillance ethical for these men?
It is a vital question. You have to look at the methodology.
Okay.
The active monitoring used in PROTECT was not the rigorous active surveillance protocols we use today. They didn't utilize multiparametric MRI to ensure they weren't missing hidden transition zone tumors.
Wow.
They didn't perform systematic confirmatory biopsies. They simply checked PSAs.
Oh, wow.
Furthermore, the radiation arm used older 3D conformal techniques, delivering 74 gray, which is well below our contemporary dose-escalated standards.
So they were monitoring blindly and treating suboptimally by modern standards.
Exactly. Even so, the metastatic rate doubled, but the mortality had not yet separated at 15 years because we have effective salvage therapies that extend life even after metastasis.
Right.
The open question is whether that doubled metastatic rate will translate into a mortality difference at 20 or 25 years, but it highlights that even low-risk disease, if completely ignored, can eventually metastasize.
Which brings us to the final datasets, the Johns Hopkins and Toronto cohorts. These represent the modern standard of highly rigorous active surveillance.
Right. The Hopkins cohort focused strictly on very low and low-risk patients. They utilized stringent entry criteria and mandated annual biopsies.
And the results?
The results at 15 years were stunning. A 99.9% cancer-specific survival, only 0.1% died of prostate cancer.
That's incredible.
However, at 10 years, 26% of men had their cancer biologically reclassified to a higher grade, and 50% ultimately underwent curative treatment.
And the Toronto cohort, which included mostly low-risk but some highly selected intermediate-risk patients, showed a 94.3% cancer-specific survival at 15 years.
Right.
The defining statistic from Toronto was the hazard ratio of non-prostate to prostate mortality, 9.2 to 1. These men on modern surveillance were over 9 times more likely to die of a heart attack or stroke than their prostate cancer.
So synthesizing these 4 datasets creates our clinical decision-making framework based on life expectancy, or LE. We estimate LE using objective tools like the Social Security tables, adjusted for the patient's specific health quartile.
Let's run the thresholds. If the patient's calculated life expectancy is less than 5 years, we do not perform staging imaging, and we offer no local treatment for asymptomatic disease up through intermediate risk. We utilize androgen deprivation therapy only if the tumor causes local bleeding or bone pain.
Right, the tortoise cannot win.
If life expectancy is less than or equal to 10 years, observation is the standard for low-risk disease. If life expectancy is greater than or equal to 10 years, rigorous active surveillance is preferred for very low and low risk. And crucially, active surveillance can be considered for carefully selected favorable intermediate risk patients. Definitive treatment is standard for unfavorable intermediate and above.
Perfect. Let's solidify the natural history trials with a mnemonic.
SPCG4 says intermediate risk kills. Pathology says low risk with comorbidity does not. PROTECT says monitoring works, but metastases double without strict protocols. Hopkins and Toronto say rigorous surveillance for low risk almost never kills.
That's it. Let's apply this directly to our 62-year-old case. He has grade group 2, favorable intermediate risk disease.
Right.
His anatomy shows a left peripheral zone lesion, safely away from the bladder neck, but abutting the fascial plane.
And his life expectancy, because he is an avid runner with minimal comorbidity, easily exceeds 25 years. The finish line is decades away.
Exactly. Because his life expectancy is so long, his competing risk of non-cancer mortality is low. He is not the sicker patient from PIVA. He has grade group 2 disease, which SPCG4 proved has a 10-fold risk of causing death over 3 decades compared to baseline if left untreated.
However, because his tumor volume is low, only 3 cores, and his density is favorable, the AUA and ASTRO guidelines fully support a nuanced, shared decision-making discussion.
Right.
We offer definitive therapy surgery or dose-escalated radiation, but we also explicitly discuss active surveillance, perhaps augmented by genomic classifier testing, to ensure the tumor lacks aggressive molecular signatures. He sits right on the fulcrum of intervention.
He really does. And the precise mechanics of those definitive treatments, how we design target volumes to respect that zonal anatomy, and the functional trade-offs between cutting the neurovascular bundles versus irradiating them, well, that will be the focus of our subsequent lectures. Today, we successfully decoded his biology.
Now we're going to pivot to oral board traps. We're going to break down 3 specific catastrophic errors that residents routinely make under pressure and explain exactly why the examiners will fail you for them.
Oh, this is so important. Trap number 1. Confusing clinical T-stage with imaging or biopsy findings.
Oh, yeah.
If the vignette gives you an MRI showing clear extraprostatic extension, but explicitly states the DRE was completely normal, and you categorize the patient as clinical T3A, you fail.
Instant fail.
The examiner is testing your adherence to the AJCC rules. Clinical key staging is DRE only. A non-palpable tumor with MRI extension remains T1C. You can verbalize that the MRI findings will influence your target volume design, but the formal stage remains T1C.
Right. Trap number 2. Failing to distinctly separate favorable from unfavorable intermediate risk.
Happens all the time.
If a patient has a PSA of 12 in grade group 2, and you vaguely state, this is intermediate risk, I will recommend external beam radiation and consider short course ADT.
Oh.
You have missed the entire biological point of the staging system.
Exactly.
You must explicitly calculate the criteria. He has 2 intermediate risk factors, the PSA and the grade group. Therefore, he is unfavorable. Favorable intermediate generally does not require ADT. Unfavorable intermediate absolutely does. Your lack of precision will lead to either undertreatment or unnecessary chemical castration. Trap number 3. Misclassifying common iliac nodes as regional disease.
Oof, yeah.
If the prompt describes an enlarged, hypermetabolic common iliac lymph node on a PET CT, and you say, the patient has N1 regional disease, I will cover the whole pelvis with radiation, you have fundamentally misunderstood the lymphatic anatomy.
Right.
Regional nodes stop at the common iliac bifurcation. A positive common iliac node is M1A, stage 4B distant metastatic disease. The primary intent shifts from localized cure to systemic control.
Got it. Let's reinforce the high-yield board.
Pearl 1. The peripheral zone accounts for 80 to 85% of adenocarcinomas and is targeted by standard TRUS biopsy. The transition zone accounts for 10 to 15% and requires MRI-targeted biopsy due to its anterior depth. Pearl 2. In the AJCC 8th edition update, all organ-confined pathological disease was condensed into a single PT2 category, eliminating the A, B, and C subdivisions. Furthermore, microscopic bladder neck invasion was biologically downgraded from PT4 to PT3A.
Pearl 3. Favorable intermediate risk is a strict triad. You must have exactly 1 intermediate risk factor, not be grade group 3, AE, have less than 50% cores positive. 1 violation equals unfavorable biology.
Pearl 4. From SPCG4, the number needed to treat with surgery to prevent 1 prostate cancer death at 29 years is 8.3. The biological risk multipliers. Extraprostatic extension increases death risk 5-fold. Gleason 7 increases it 10-fold.
Pearl 5. The regional lymphatic basin includes the obturator, internal iliac, external iliac, and presacral nodes. The dividing line is the common iliac bifurcation. Above that is M1A distant disease.
All right, time for the board blitz. I'm going to fire 3 case vignettes, and we will dissect the answers. Question 1. A 58-year-old man undergoes a biopsy for a PSA of 8.2. His DRE is entirely normal. An MRI shows a PI radius 4 lesion in the right peripheral zone with no extraprostatic extension. The biopsy shows Gleason 4 plus 3 7, which is grade group 3, in 7 out of 12 cores, meaning 58% involvement. What is his exact NCCN risk category? A, favorable intermediate risk. B, unfavorable intermediate risk. C, high risk. D, very high risk.
The correct categorization is B, unfavorable intermediate risk.
Let's hear the logic.
Okay, let's trace it. His clinical T stage is T1C because the DRE is normal. His PSA is less than 10. He does not possess any high-risk features, meaning no T3A, no grade group 4 or 5, and his PSA is not 20 or higher.
Right.
This restricts him to the intermediate bucket. Now we apply the split criteria. He has grade group 3 disease, which indicates the cellular architecture has fused and lost adhesion. He also has 58% positive cores, indicating high tumor volume.
Yep.
Either of those factors alone immediately disqualifies him from the favorable category. So therefore, he is unfavorable intermediate risk.
Excellent. Question 2. A 71-year-old man with a severe medical history, including poorly controlled diabetes, COPD requiring home oxygen, and a prior myocardial infarction has a PSA of 5.1. His biopsy shows grade group 1, Gleason 3 plus 3, in 2 of 12 cores with 15% maximum involvement. His DRE is normal. His PSA density is 0.10. His life expectancy is estimated by his cardiologist at 5 to 7 years. What is his risk category, and what is the biological implication based on natural history? A. Very low risk. Prostate cancer is very likely to cause his death. B. Low risk. Prostate cancer is moderately likely to cause his death. C. Very low risk. Prostate cancer is very unlikely to cause his death. The answer is C. He is very low risk, and the cancer is very unlikely to cause his death.
Break it down.
First, confirm the criteria. T1C, grade group 1, PSA under 10, less than 3 positive cores, less than 50% core involvement, and a density under 0.15. He checks every box for very low risk.
The implication relies on the competing risk framework. The Toronto surveillance data proved that men with this biology are 9 times more likely to die of non-prostate causes.
All right.
Because his life expectancy is severely limited by cardiovascular and pulmonary disease, the hairs are running incredibly fast. The slow-moving grade group 1 tortoise will not cross the mortality finish line first. Treatment would only induce morbidity without extending his life.
Perfect application of the framework. Question 3. A patient undergoes a radical prostatectomy. The surgical pathology report reveals grade group 3, Gleason 4 plus 3. The tumor is completely organ-confined on all posterolateral and apical sections, except 2 for microscopic tumor cells found infiltrating the smooth muscle bundles of the bladder neck. Surgical margins are positive at the bladder neck. 14 pelvic lymph nodes are dissected and all are negative. What is the pathological stage to the AJCC 8th edition? A. PT2N0, B. PT3A-N0, C. PT3B-N0, G. PT4N0.
The answer is B, PT3A-N0.
Explain why.
This is testing your explicit knowledge of the 8th edition biological downgrading. Microscopic bladder neck invasion is no longer considered organ confined, so it cannot be PT2. There is no mention of the tumor infiltrating the muscular wall of the seminal vesicles, ruling out PT3B.
Right.
Historically, this would have been staged as PT4 gross invasion, but the AJCC recognized that microscopic infiltration here behaves identically to standard extraprostatic extension, hence the PT3A classification. Additionally, while the positive margin indicates an R1 resection, it does not alter the pathological T stage itself.
That perfectly encapsulates the staging rules. To summarize our session, zonal anatomy is destiny. The peripheral zone originates the majority of cancers and sits perilously close to the rectum and the neurovascular bundles, dictating both our diagnostics and our radiation constraints.
Right.
Risk is governed by the 4 pillars: DRE-driven clinical T-stage, PSA density, grade group cellular architecture, and core percentage volume. Natural history proves that competing risks must govern every decision. You must accurately calculate the speed of the tortoise against the speed of the hare.
Before we conclude, consider this provocative shift happening right now in our field. We base our entire risk stratification on the ISUP groups, relying on a human pathologist to look through a microscope and subjectively decide if a gland is poorly formed enough to push a patient from grade group 2 to grade group 3, shifting them from surveillance to definitive treatment.
True.
But digital pathology AI algorithms are now capable of analyzing millions of pixels, quantifying cellular morphology with mathematical precision that humans simply cannot match. If an algorithm regrades a favorable tumor as biologically aggressive based on subvisual architectural chaos, do we trust the human or do we trust the machine? It is a biological and ethical frontier you will face in your practice. Complete practice oral boards at radoncsmartlearn.com and subscribe to Radonc Smart Review for our next episode. Thanks for tuning in.